Multiple sclerosis, MS, is an autoimmune condition that affects your brain and spinal cord, central nervous system. With MS, your immune system mistakenly attacks myelin cells. These are the protective covers, sheaths, that surround your brain and spinal cord nerves. Myelin sheath damage interrupts messages, signals, that your nerves send throughout your body to perform functions like vision, sensation and movement. Myelin damage can occur in your brain, spinal cord and nerves that supply your eyes. As a demyelinating disease, MS disrupts the nervous system's ability to transmit signals, resulting in a range of signs and symptoms, including physical, mental, and sometimes psychiatric problems. The body's immune system mistakenly attacks the central nervous system, specifically the myelin sheath that insulates nerve fibers. This immune response is driven by both innate and adaptive immune cells, leading to inflammation, demyelination, and ultimately, neurological dysfunction. Key players in MS immunology: T cells. Both CD4+ and CD8+ T cells are involved in the inflammatory process, with Th1 and Th17 cells being particularly implicated in the pathology of MS. These cells release inflammatory cytokines like interferon gamma and interleukin-17, which contribute to myelin damage. B cells. B cells also play a role in MS, potentially through the production of antibodies that target myelin components and by acting as antigen-presenting cells. Innate immune cells. Microglia and macrophages within the central nervous system are activated and contribute to the inflammatory response and myelin damage. Natural killer cells may also contribute to the disease process. Antigen presentation. Dendritic cells and other antigen-presenting cells, APCs, play a crucial role in activating T cells by presenting myelin antigens. Pathogenesis of MS. Breakdown of immune tolerance. In MS, the immune system loses tolerance to myelin, leading to an autoimmune response. Blood-brain barrier disruption. The blood-brain barrier, which normally protects the CNS, is compromised, allowing immune cells to enter the brain and spinal cord. Demyelination. Immune cells attack and destroy myelin, disrupting nerve signal transmission and causing neurological symptoms. Neurodegeneration. In addition to demyelination, MS is also characterized by neurodegeneration, where nerve cells and their axons are damaged. Essential features. Most common immune-mediated demyelinating disorder of the central nervous system and most common cause of non-trauma-related neurologic disability in young adults. Female predominant neurologic disorder consisting of episodic nervous system dysfunction and characteristic radiologic findings that demonstrate both dissemination in time, multiple episodes, and dissemination in space, multiple lesions seen on imaging. Factors contributing to MS. Genetic predisposition. Certain genes, particularly those in the human leukocyte antigen, HLA, region, increase susceptibility to MS. Environmental factors. Environmental factors like viral infections, e.g., Epstein-Barr virus, vitamin D deficiency, and smoking are also implicated in MS development. Therapeutic implications. Understanding the immunology of MS is crucial for developing targeted therapies. Current treatments aim to modulate the immune response, reduce inflammation, and protect myelin. Sites. Can involve any site in the central nervous system, CNS, typically within the white matter but also involves the gray matter. Brain 2019, 142 to 1858. Most common sites for MS plaques. Optic chiasm and tract. Nearly always involved, paraventricular white matter. Subcortical white matter. Deep gray nuclei. Paraventricular areas of the brainstem, cerebellum and spinal cord. MS lesions can affect any part of the central nervous system, so a person with MS can have almost any neurological signs or symptoms. Fatigue is one of the most common symptoms of MS. Roughly 65% of people with MS experience fatigue. Of these, some 15 to 40% report fatigue as their most disabling symptom. Autonomic, visual, motor, and sensory problems are also among the most common symptoms. The specific symptoms depend on the locations of the lesions within the nervous system and may include loss of sensitivity or changes in sensation in the limbs, such as tingling, pins and needles, or numbness, limb motor weakness or pain, blurred vision, pronounced reflexes, muscle spasms, difficulty walking, or with coordination or balance, ataxia, problems with speech, 30, or swallowing, visual problems, optic neuritis manifesting as eye pain and vision loss, or nystagmus manifesting as double vision. Fatigue, and bladder and bowel difficulties, such as urinary or fecal incontinence or retention, among others. When MS is more advanced, walking difficulties lead to a higher risk of falling. Difficulties in thinking and emotional problems such as depression or unstable mood are also common. The primary deficit in cognitive function that people with MS experience is slowed information processing speed, with memory also commonly affected, and executive function less commonly. Intelligence, language, and semantic memory are usually preserved, and the level of cognitive impairment varies considerably between people with MS. Uthoff's phenomenon happens in people with multiple sclerosis. When the body gets hot, from exercise, a hot bath, or even fever, MS symptoms can temporarily get worse. Why? Because heat slows down the nerve signals in damaged areas. This can cause blurry vision, weakness, or numbness. But don't worry, it's not a new attack. The symptoms go away once the body cools down. So, staying cool is important for people with MS. Thermite's sign is a sudden, electric shock-like feeling. It travels down the neck and spine, and sometimes into the arms or legs. It usually happens when you bend your neck forward. This sign is common in people with multiple sclerosis or other spinal cord issues. It happens because of damage to the nerves in the cervical spinal cord. The shock sensation is brief, but it can be uncomfortable. If you feel this often, talk to your doctor. Thermite's sign is not dangerous, but it's a sign something may be wrong in the nervous system. MS may also present with eye movement impairments such as internuclear ophthalmoplegia or sixth nerve palsy. The Expanded Disability Status Scale, or EDSS, is a tool used to measure disability in people with multiple sclerosis. It helps doctors track how MS affects the body over time. The scale ranges from 0 to 10. 0 means normal neurological function. 10 means death due to MS. As the number goes up, it reflects more disability. The EDSS focuses on walking ability, but it also considers other body systems, like vision, coordination, and bladder control. For example, a score of 3 means mild disability but full mobility. A score of 6 means you need a cane or crutch to walk. At 7 or higher, you may need a wheelchair. The EDSS helps guide treatment decisions and monitor disease progression. Checkmark optional addition at the end. EDSS is not perfect. It mostly measures physical disability and may miss fatigue or cognitive problems. Still, it's widely used in MS care. Multiple sclerosis has different types, based on how the disease behaves over time. Here are the main types. Cyclone 1. Relapsing remitting MS, RRMS. This is the most common form. People have flare-ups or attacks, followed by periods of recovery. Downward trend 2. Secondary progressive MS, SPMS. It starts as relapsing remitting MS, but over time, the symptoms steadily worsen, with or without relapses. 3. Primary progressive MS, PPMS. Symptoms slowly worsen from the beginning, without any clear relapses or remissions. Repeat button 4. Progressive relapsing MS, PRMS, now called a rare form of PPMS. It shows steady progression with occasional acute relapses. These types help doctors choose the right treatment and predict how the disease. Brain prodromal phase, before diagnosis, may occur years before MS is diagnosed. Includes psychiatric symptoms, cognitive decline, increased use of healthcare services. Stethoscope onset. 85% start as clinically isolated syndrome, CIS. Common initial symptoms: motor, sensory problems, 45%. Optic neuritis, 20%, vision loss, eye pain, down-pointing arrow color vision, brainstem symptoms, 10%. Multiple symptoms, 25%. Optic neuritis equals common early sign. Important to rule out similar diseases, e.g., NMOSD. Anti-clockwise arrows course patterns. Relapsing remitting, 85%, sudden attacks, relapses, followed by recovery. Progressive, 10–15%, gradual worsening without recovery. Some may start as relapsing and become progressive later. High voltage relapses, often unpredictable, is less than or equal to 2 per year. May be triggered by spring, summer. Infections, e.g., cold, flu, gastroenteritis, stress. Not triggered by vaccines. Breastfeeding. Physical trauma. Uthoff's phenomenon. Pregnant woman pregnancy. Symptoms improve during pregnancy. Higher relapse risk in first 3 months after birth. No long-term effect on disability progression. Test tube diagnosis overview. MS is mainly a clinical diagnosis, based on history, neurological exam, and MRI findings. Use 2017 McDonald criteria. Helpful when MS is suspected clinically. Additional helpful tools. Evoked potentials. Test nerve responses. Optical coherence tomography. October. Checks optic nerve damage. Microscope laboratory tests. Lumbar puncture not always needed, but can support diagnosis. Look for oligoclonal Ig bands in the CSF. Helpful when MRI shows multiple lesions but no clear time spread. CSF findings in MS. Mostly T lymphocytes. Normal protein levels. Dawson fingers. Lesions perpendicular to ventricles, sagittal view. Contrast enhancement shows active inflammation. Tumefactive MS. Shows an open ring lesion with contrast. Black holes. Chronic plaques appear dark on T1, permanent damage. Healed plaques become iso-intense, normal tone, on T1. Petri dish gross, macroscopic, appearance of MS plaques. Chronic, old, lesions, round, tan gray in color. Clearly defined edges, vary in size. Recent, newer, lesions, tan pink or tan yellow. Blurred edges, less sharply demarcated. Spinal cord lesions, fanned out shape. Sharp borders, may affect multiple nerve tracts. Orange circle active MS plaque. CD8 plus T cells cluster around blood vessels. Macrophages, some filled with myelin debris, seen on LFB, postain. Loss of myelin, but axons are mostly preserved. Axonal swellings, spheroids, reactive astrocytes, astrocytosis, partial remyelination at the plaque edges, with thinner sheaths. White circle chronic, inactive, MS plaque. Low cell count, very few or no inflammatory cells. Severe myelin loss with sharply defined edges. Only a few oligodendrocytes at the border. Reactive gliosis, scar-like response. Balloconcentric sclerosis, rare type, alternating rings. Demyelinated plus preserved myelin. Active rings resemble typical active MS plaque. Marburg type, aggressive form, many active plaques with blurry borders. Rich in macrophages, T cells, and astrocytosis. May show edema or necrosis.